Welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you so much for returning. And speaking of returning, we're going to be speaking with returning guest Dr. Keyan Salari. He's a urologic oncologist and surgeon, co-director, Prostate Cancer Genetics Program at Massachusetts General Hospital. He's returning to talk about his study that was presented at the AUA 2022. Welcome back, Keyan. How are you? Thank you for joining.
I'm doing well. Thanks for having me back.
Well, for those who aren't familiar with you as a contributor, give us a brief look into your professional background and talk briefly about your role there at Mass General.
Sure. So I'm a urologic oncologist at Mass General Hospital, which means I'm a urological surgeon for genitourinary malignancies, focused mainly on prostate cancer. My research lab focuses on the genetics and genomics of prostate cancer, and so that's my main area of research focus.
Your study is entitled The Impact of Family History and Germline Genetic Risk Variants on Long-Term Outcomes of Active Surveillance-Eligible Prostate Cancer. It was presented, as I said in the outset, at the AUA 2022. Tell us about this information, this research that you presented.
Sure. So when people think about genetic susceptibility to developing prostate cancer, and first I'd say that prostate cancer is one of the most heritable cancer types. And so we think of family history, rare genetic variants like BRCA1, BRCA2 mutations that many folks have heard about, as well as common genetic risk variants like single nucleotide polymorphisms. These are all different forms of genetic susceptibilities and different ways of measuring or capturing genetic susceptibility. And so there's been a number of studies over the years looking at each of these individually, but there's been very few studies that have examined the combined prognostic impact of family history and germline risk variants in prostate cancer. I've been interested in not just looking at the risk of developing prostate cancer with either family history or germline genetics, but also in how these genetic factors can impact the prognosis. So meaning how aggressive a prostate cancer is going to be. I think when we had spoken in previous sessions, we talked about active surveillance for prostate cancer, which is where we deem a cancer low risk enough that we think we can monitor it instead of treating it as a way to avoid some of the side effects that go along with prostate cancer treatments like surgery or radiation and hormone therapy. And so as long as a prostate cancer is looking indolent enough, meaning that it's low risk by all of our kind of standard clinical and pathologic features, we often just monitor those patients. We don't treat their cancers, and that's what we call active surveillance. But it turns out that in a number of cases, we are wrong about that assessment, or over time that changes. So if we, at our own institution, look at our patients that we've put on active surveillance, up to about a third of them end up coming off surveillance within 5 years, and up to half of them by 10 years. Now, you could look at that half glass full, half glass empty. You could say, half the patients by 10 years we were wrong about, and they actually did need treatment. Their tumors were not as indolent as we first thought they were. You can also look at the other way around and say, well, at least half the patients we were able to still by 10 years avoid treatment and the toxicities that come along with those treatments. What I've been interested in trying to do, as a number of my colleagues have as well, is try to improve our ability to predict who is really a good candidate for active surveillance, meaning who has truly indolent disease that you could safely monitor, whereas or compared to who has truly more aggressive disease that probably ought to be treated right off the bat instead of monitoring it for a period of time and giving it the opportunity to potentially progress. That's kind of the background that is relevant to why we're looking at genetic factors to see whether whether there's anything at the genetic level that could help us predict whether a tumor is more likely to progress on surveillance and need treatment versus remain indolent and be able to be safely monitored.
Was there a look at whether or not it was more aggressive if there were family history and genetics involved as opposed to solely environmental causes of a person's prostate cancer diagnosis?
Yeah, that's a great question. And the interesting thing with prostate cancer is that there aren't very many environmental risk factors that have been kind of reliably or robustly validated over the years in various cohorts. And so, we still think of just really the unmodifiable risk factors like age, of course, and family history. There's, of course, associations with genetic ancestry or racial background. There's not as much environmental risk factors that have been, outside some very rare exposures like things like Agent Orange and Vietnam veterans and things like that, that have been identified as significant risk factors. BMI is one risk factor that has been identified. But the perfect cohort to look at these types of things is the cohort we turned to, which is the Health Professionals Follow-Up Study, which is a longitudinal prospective cohort study managed by the Harvard School of Public Health. And that's where we turned to investigate this question of family history and germline genetics. So just to introduce that cohort, it's a cohort of about 51,000 U.S. male health professionals who have been followed actually since the mid-1980s. And so this is a very robust, large prospective cohort study that has been used to study many different conditions. And we're just looking at the data on the men with prostate cancer. And we kind of drilled into the patients who have been diagnosed with prostate cancer since 1986 when this cohort was started. So over the last 30 plus years, and categorized them to look at men who would have been eligible for active surveillance. Of course, back then in the 80s and 90s, when a lot of these men were being diagnosed, we weren't doing active surveillance back then. So we were looking to see in our modern criteria for how we would select somebody for active surveillance with NCCN, low risk or favorable intermediate risk prostate cancer. How did those patients do over time, and whether there was any impact with family history or other genetic risk variants that we have obtained on these patients. So there's about 1,300, a little over 1,300 men we looked at with low risk or favorable intermediate risk prostate cancer who had genome-wide SNP genotyping data, so single nucleotide polymorphism genotyping data available, as well as details about their family history. One just quick comment is that we learned from actually a different study of our own active surveillance cohort at Mass General that it turns out family history of prostate cancer alone is not the only relevant family history, but also a family history of related malignancies, genetically related malignancies like breast cancer or pancreatic cancer also seem to have an impact on risk on active surveillance. And so that's something we learned in a separate study of ours at Mass General. And so when we did this study, we looked in the health professionals follow-up group at the men who had family history in their first degree relatives of either prostate, breast, or pancreatic cancer. So that was our family history measure. And we looked at around 269 prostate cancer related polymorphisms, single nucleotide polymorphisms that have been developed into what we call a polygenic risk score, essentially a risk score based on these 269 SNPs that have been validated in previous studies as being associated with the risk of prostate cancer development. And then we look to see over the 30 plus year follow-up, who had recurrence of their prostate cancer and as well as who died of prostate cancer. There's 263 recurrences, 52 deaths. And then we built statistical models to look at how family history and genetic risk impacted that. What we found is about a third of patients had a family history of one of those three malignancies that I mentioned. And it turned out that having that family history increased the risk of prostate cancer specific death significantly. About 8, the hazard ratio was about 1.8. So about an 80% increase in risk of prostate cancer specific death. And that was being adjusted for age, PSA, grade, stage, and the primary treatment strategy for those patients. So the second significant finding was in the germline risk variants, where the polygenic risk score itself was actually not associated with prostate cancer specific death, but specifically one of the loci, the chromosome 19q13, one of the alleles there we found had about, again, an 80% increased risk of prostate cancer specific death after adjusting for the same factors as we did for family history. And it turned out that these were actually independent risk conferred by both family history and the germline risk SNP. So in a model where we had both heritable factors, both the family history factor as well as the 19q13 risk allele, each of these factors contributed independently to predicting prostate cancer specific death. So in summary, we found that patients with favorable risk prostate cancer who had a first degree family history of either prostate, breast, or pancreatic cancer, or who had a 19q13 germline risk allele, had significantly elevated risks of prostate cancer specific death. So we feel that these findings have important implications for how familial and germline genetic risks should be considered into clinical decision-making around active surveillance for prostate cancer.
How impactful would you say that these findings are to the field of urology? And then give us a website where we can learn more about Mass General and about this study and go further into it.
Sure. Yeah, so the main takeaway is that finding that not just family history alone, but also one of the risk loci on chromosome 19q13, each of these factors, either family history or that risk SNP, significantly elevated the risk of prostate cancer death. So the main implication there is that it really makes us think about how we select patients for active surveillance and whether or not these types of factors should be considered into the decision making about whether to put someone on active surveillance or how to counsel them as they're making their decisions about staying on surveillance. And you asked for the websites for Mass General is www.massgeneral.org.
Keyan, always a pleasure, always some great information for us. I'm looking forward to our next conversation. Thank you so much for returning tonight.
My pleasure. Thank you very much.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with returning guest Dr. Keyan Salari. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at SoundCloud, and be sure to subscribe to our YouTube channel at youtube.com Health Professional Radio.